So we are continuing the next question, our previous year NEET PG question series. We'll start with 2024 questions. So we'll discuss cardiology questions initially. So this is an ECG question. A patient with recent myocardial infarction collapses in hospital ward. He was found unresponsive. Pulses were absent. CPR was started. ECG is as follows. What is the next appropriate step? So we have to diagnose this ECG and we have to tell what is the next step of management. So understanding this question, a patient with a history of myocardial infarction who is in the hospital ward, he collapses. So he is unresponsive, means he has lost his consciousness and pulses were absent. So this is clearly a case of cardiac arrest. Okay, it is not a live patient, he has collapsed. It's a case of cardiac arrest. Whenever it is cardiac arrest, you need not worry about ECGs because I think in our previous questions we had discussed about the different rhythms. Narrow complex rhythms and wide complex rhythms, tachycardia rhythms and bradycardia rhythms. But if it is a case of cardiac arrest, you need not worry much. In fact, anyone, even if you are not going to pursue medicine in future, you must know the 4 cardiac arrest rhythms. The 4 cardiac arrest rhythms are classified into shockable rhythms, and non-shockable rhythms. There are 2 shockable rhythms. One is a pulseless ventricular tachycardia and ventricular fibrillation or VFib. There are 2 non-shockable rhythms. They are asystole. Other one is pulseless electrical activity. We'll discuss this ECG. So when you are stuck up in an ECG in the NEET, just try to discern each of the ECG waves. So are you able to make out the P wave here? No. P wave means atrial depolarization. So when P wave is not present, the atrium is not getting depolarized. So the rhythm does not originate above the ventricle or it does not originate from the atrium. So there is no atrial depolarization as there is no P wave. We are able to see only one wave, right? There is only one wave here and this is definitely a wide. One of our cases we discussed, when the wave is wide means it is more than 3 small squares. So if we start from here also, this is about 3 to 4 small squares, right? This entire wave. So definitely this is a wide complex and this is tachycardia, right? The number of number of large squares between 2 R waves is around 1 or 2. So you know the formula. The heart rate is given by 300 divided by the number of big squares between 2 R waves. So around 2 means it comes around 150. So this is actually a wide complex tachycardia. All wide complex rhythm means they originate from the ventricle. So this is probably a ventricular tachycardia. So that is what we are able to make out from this ECG, right? It is a wide complex rhythm. There is no P wave and there is tachycardia. So this is a wide complex tachycardia, probably a ventricular tachycardia. But we already told among these 4, which does this one fit? So this is ventricular tachycardia. This is a cardiac arrest, so patient does not have pulse. So this probably will be a pulseless ventricular tachycardia. So before going to the treatment, I'll just show you the other ECGs. This is the ECG which we just saw. It's a wide complex tachycardia. This is regular rhythm. So this is a VT, ventricular tachycardia. Remember, ventricular tachycardia can occur both in an alive person as well as during a cardiac arrest. During cardiac arrest, there will not be pulse. So the VT occurring in cardiac arrest patient is called as pulseless ventricular tachycardia. In alive case, it's simply called as ventricular tachycardia. There are furthermore classifications of ventricular tachycardia. We won't discuss this. So what about the second ECG? The second ECG, also there is tachycardia. Heart rate is around 150 per minute. So this is definitely tachy. Is this narrow complex or wide complex? This is also wide complex. So this is also wide complex tachycardia. This is somewhat irregular. But one striking difference between first ECG and second ECG is, see, the morphology of every wave is similar. Right? It is the morphology of every wave is similar in the first ECG, whereas here one wave is small, one is large. See, it comes like this: few are small, few are large. So this is called as polymorphic ventricular tachycardia. Polymorphic VT. The first one we can call it as a monomorphic VT. Even if you don't remember monomorphic VT, try to remember polymorphic VT, very important, because polymorphic VT is also called as torsades de pointes, TDP. One important cause of torsades de pointes is any condition causing QT prolongation. Any condition causing QT prolongation. It may be due to many reasons. There are some syndromes called as congenital long QT syndrome. So congenital reasons may be there. There are some drugs, example fluoroquinolones, antimalarials, antipsychotic drugs. They can prolong QT interval. Then some electrolytes. Example, hypocalcemia, hypomagnesemia. So there are still many more causes, but please remember there are congenital causes of QT prolongation. Some drugs can cause QT prolongation. Some electrolyte abnormalities can cause QT prolongation. Until torsades de pointes develops, patient will be stable. But once they develop torsades de pointes, it is a wide complex unstable tachycardia. So here magnesium has to be given. Please remember. Okay, so monomorphic VT and polymorphic VT. Polymorphic VT may or may not be a cardiac arrest rhythm. Okay. Now what is this ECG? We can see few white complexes. We cannot see any definite wave. But this is very, very irregular. Anything which is irregular is called as fibrillation. But in atrial fibrillation, we can make out Q waves. We can make out QRS complexes. But here we are not even able to make out QRS complexes. So this is a ventricular fibrillation. So these three are ventricular based rhythms. We have ventricular tachycardia and ventricular fibrillation. In the setting of cardiac arrest, there will not be pulse. So VT is called as pulseless VT. VFib will not have a pulse. These two are called as shockable rhythms, cardiac arrest rhythms. So basically, patient goes for a cardiac arrest, you are seeing the ECG. If you are seeing white complex, it is shockable. You have to give a shock. Whereas, see these two ECGs. There is no wave, so this is called as asystole. What about this ECG? This may look normal. The ECG looks normal, but I told you this is an ECG taken in the setting of a cardiac arrest. So patient does not have a pulse. So patient does not have a pulse, but if you are seeing the ECG monitor, patient is having a normal ECG, then also it's a cardiac arrest rhythm. It is called as pulseless electrical activity. Right? So asystole and pulseless electrical activity, these are called as non-shockable rhythms. Which means there is no role of giving a shock. Only CPR and adrenaline or epinephrine is the treatment of choice here. Whereas in shockable rhythm, we have an additional step, that is giving shock. Now when knowing about the term shock, Please remember, in your questions you may get confused between DC shock, that is DC is DC cardioversion, or simply the term cardioversion. Whereas another term is there, which is defibrillation. Cardioversion and defibrillation. There's a device, right? Implantable cardioverter and defibrillator. Cardioversion, just remember here patient is stable. Even though they have some arrhythmias, patient is stable, means they are not going in for arrest or they don't have hypotension. Then it is called as DC shock or cardioversion. When the same shock is delivered in an unconscious patient or a cardiac arrest patient or in a very sick patient, we use the term defibrillation. The shock, the joules delivered is different. Okay. So we'll read the options here. So definitely it's a white complex tachycardia. It's a pulseless monomorphic VT. What is the next appropriate step? Whether you will give defibrillator. Yeah, definitely, because it's shockable. Patient is in cardiac arrest, so defibrillation is the answer. You will check the pulse and perform CPR. I think this order is not right, because in your resuscitation, in your adult cardiology life support, once you give shock, the next time you must do is to start CPR immediately. You must not wait and see the pulse. Okay, because cardiac arrest is both the mechanical as well as electrical activity. Electrical activity stops, heart does not pump. On giving defibrillation, we are bringing back the normal electrical rhythm, but still the mechanical activity will not be present. So there is no point in checking pulse. So immediately after defibrillating, even though the rhythm comes, you must perform CPR immediately, and then only you should check for the pulse. Cardioversion may not be the answer. Just now we discussed. Because cardioversion is a shock given in a stable patient, defibrillation is the shock given in an unstable patient. Option C, defibrillator. Yeah, definitely. Perform CPR. That's what we told. Give the shock, start CPR immediately, and then only you should check pulse. So C seems appropriate. D is administer epinephrine. Of course, this is also a step in your adult cardiac life support. Shock, CPR, giving adrenaline. That's how the sequence goes. But the question is, what is the next appropriate step? So C is more appropriate than D. Because once you recognize a shockable rhythm, first thing which we have to do is to give shock. Okay. So we just discussed about some basic ECG interpretation, cardiac arrest rhythms, about polymorphic VT, and the treatment here.